I'm Alan Schulman, and I'm a neurologist here at HCA Neurological Associates. In addition to neurology board certification, I also have a certification in sleep medicine. So I see a lot of patients for sleep-related issues and have a lot of MS patients, but also see all types of general neurology patients. I also work inpatient in the hospital about 1 week a month, and of course see lots of different inpatient type neurological conditions, including stroke. There are two types of stroke. The more common type of stroke is a clot-related stroke, or ischemic stroke as we call it. And then roughly about 20% of strokes are due to bleeds in the brain, or hemorrhagic stroke. Fortunately, other than neurosurgical treatment for certain types of bleeds in the brain, we don't have medical treatments yet for hemorrhagic strokes. But for ischemic strokes, we do have treatments. For over 20 years, we've had a clot-buster drug called TPA that's given intravenously. And particularly in the past several years, we've been using for large vessel strokes more and more a procedure called thrombectomy, which is where we can go in and mechanically remove a large vessel clot from a blood vessel. So stroke can present with a lot of different symptoms, and one of the tricky things about stroke is that, unlike a heart attack where somebody usually has a lot of pain and gets their attention very quickly, most strokes are painless. And so if they're having neurological symptoms, people can kind of shrug it off or say, well, maybe I woke up, with my foot asleep, etc. But there are a lot of different symptoms that people can have with the stroke. Some common ones are weakness, both facial weakness as well as weakness in the arms or legs. People can have decreased sensation in the arms and legs as well as the face. Language and speech disturbance are very common symptoms with stroke. And there can be less common symptoms of stroke, particularly strokes that occur in the back of the brain, which we call posterior circulation strokes. People can have symptoms such as double vision, involuntary eye movements, vomiting, nausea, dizziness. So there are really a lot of different symptoms depending on which part of the brain has been affected by the stroke. We really recommend that patients who are having stroke symptoms not drive themselves or have somebody else drive them to an emergency room, but call 911. One of the reasons we stress that patients or families should call 911 is to activate the EMS system. And by doing that, that also activates stroke systems at the hospitals and better prepares us in the emergency room to evaluate and treat the patient. So they are usually very quickly evaluated by the emergency room doctor. If a neurologist is in-house, they usually quickly evaluate the patient as well. Here at HCA, for a number of years after hours, we've been using telestroke, which means we as neurologists are seeing the patients by video. And so instead of delaying having to drive in to see the patient, we're seeing the patient more quickly by video. But they're very quickly assessed to make sure there are not other issues going on. Then usually we very rapidly get a CAT scan of the head to make sure that there's no bleeding in the brain. And then the next step is typically to determine if they are a candidate for the clot-buster drug TPA. And there are a lot of kind of exclusion criteria that might not allow them to receive that medication, if they're on certain blood thinners, if they've had a stroke recently, other things that we feel it's too dangerous for them to receive the clot-buster drug TPA. But if they are eligible, we want to give that as quickly as possible, because we know studies have shown the quicker you receive it, the more opportunity there is to help reduce the symptoms of a stroke. If somebody has received TPA, but we feel that this is what we call a large vessel stroke, we do other imaging of the blood vessels to help us determine whether there is a large vessel clot. And if that's the case, they could be a candidate for mechanical thrombectomy, where we go in, physically remove the clot itself. The other thing is that some patients who are not eligible for the intravenous drug TPA can still be eligible for the mechanical thrombectomy if there is a large vessel clot. And we really are using that more and more in the past couple of years 4 large vessel clots. Several years ago, multiple studies were finally shown to show a clear benefit from that treatment. And so here in Richmond, we're using that much more than we have even several years ago. The primary care doctor is probably the most important part of this because they're the ones who are the experts at prevention. We feel that a good number of strokes are preventable by treating risk factors for stroke: diabetes, high blood pressure, atrial fibrillation, etc. So care really begins with the primary care doctor with prevention, and then both prevention of primary strokes and prevention of secondary strokes after somebody has had a stroke.